clinics. Eventually, we're going to start with 5 clinics, but eventually it's going to be through all of our clinics. And they will learn by experience. They will be trained by what I think are the best psychiatrists in business, because we've been doing this for a long time. And so I'm hoping that's going to be a real direct conduit to bring in these psychiatrists. And I've been personally participating in their training as well. I think that's something that I've always loved to do in my career. I've always been affiliated with academic programs, and so I provide direct training at Charles Drew as well too. So that's something else I do. Okay, what else? I also am the representative for all of the affiliations agreements. Our biggest affiliations agreement is at UCLA. They provide us with extensive training, not just in psychiatry, but all of our disciplines are trained by UCLA. My goal with that is not just to have training, because I think training is only the first step. If you just provide training, you're not going to be able to implement it, because everybody has full-time jobs already. You tell them to do something new, when are they going to find the time? So the key is not the training, the key is implementation, and that's the real science. Anybody can be trained, but implementation is the strategy that we need to follow through. And to look at how good we are at the training, how good we are at implementation, we need to really start monitoring outcomes and not just implementing ideas. Ideas are great, they may sound good, but the outcomes may not be there. So I'm actually pushing UCLA and all of our other affiliates to really try to evaluate for us the outcomes of their wonderful training. And so that's a key for us to really move forward. So that's something we're doing, that's something we're changing. The intention over the course of time is to really establish a presence in every single training program in Los Angeles County, and establish a presence in every primary care center that doesn't have psychiatric follow-up. We believe we're the best psychiatrists in the business. We believe we're the best mental health professionals in the business, all of us, because this is what we do for a living. We're mental health providers in a massive public health system, the largest in the country, actually. Mm-hmm. So we really want to put ourselves in there and provide direct consultation to patients. And so that's my ultimate goal, is to actually have a presence in every single one of the DHS clinics, and even eventually to some of the private clinics that we affiliate with. So it's a big mission, something I'm very passionate about. I think we're going to get there. I know I'm missing a few things here, but would you like to hear the stuff that I've been assigned afterwards, after I came in? So the first thing that happened when I came into DMH is Curly Bond said, oh, by the way, pharmacy is now under your control. Your pharmacy reports to you. And that's been the case. I've taken on that duty with a lot of vigor and passion. I know that pharmacy needs to improve in our system. And I believe that, fortunately, they asked me because I can kind of think like a pharmacist if I need to. I don't just take it from an advocate of psychiatry. That's not what pharmacy is. So I've been the psychiatric advocate of pharmacy. We're trying to institute a program across the board that really is going to be more effective for our patients. And that means we need to have more robust presence in all of the clinics, provide medications in a way that is novel, in a way where patients don't have to go travel to pharmacies all across the town in order to get their medications. We always talk about how difficult it is for us to bring patients into the clinics. Our no-show rates are miserable. And a big part of that is because, well, you know, if you're looking for jobs, if you're looking for where to hang your hat every single day, you may not have time to get into a mental health appointment. You know, there are priorities in the world, and having a roof over your head is obviously the primary priority. And it's the best antidepressant there is, by the way. So we have to realize that. So our goal is to bring ourselves to the patients where they live, and that's really key, because they're not all going to come to the clinics. Unfortunately, as you all know, the sad part of this business is there are a lot of people who don't know that they're mentally ill. And so we can't expect them just to come jump into our clinics and get care when they don't think that they're ill. And so we want to get out there, especially psychiatrists. We have a street psychiatry program now. I filled three of the 4 spots, I think, for next year. We're gonna go out there. I don't believe in this paradigm of psychiatrists just sitting in an office and waiting like a king on a hill for the rest of the team to bring patients into them and talk to them. I think the psychiatrists need to be out there, and I liken it to a beat of a cop in an urban center. You know, the urban center is suspicious of police right from the start. But when they see the same cops walking back and forth down the streets, eventually they might strike up a conversation with people on the field. Eventually start talking about the Dodgers, the Lakers, they grow that trust. And then maybe they start talking about what's been going on in the community as far as crime goes. Same thing is true for psychiatrists and for mental health professionals in general. There's a lot of suspicion out there of mental health professionals. Unfortunately, I've seen this because I used to work at DHS. A lot of people being brought in on 5150s who may not necessarily merit 5150s. And so there are a lot of people who come in off the street for the first time after gaining that courage that they need just to make that step, to get into the clinic. And they come in, and sometimes the first thing that happens is they're placed on a 5150 and shuttled to a hospital. That just destroys trust. So we really want to be judicious about our use of involuntary holds. But then, yeah, so there's a lot of suspicion there, and I think some of it is warranted. So our goal is to get out there and engage the community where they live, where they congregate, and what I mean by congregate, and where the community resources are, right? Not just where our community resource is in a particular DMH clinic, but we need to get out there and really provide the support out there. I think this is going to be really wonderful, and I talked to you about the training programs. They're all thrilled by the idea of street psychiatry right now. So I think this is a time we cannot waste, and we'll get that going. So pharmacy, we're trying to make our medications more affordable to our system by making better deals with the drug companies, and not just accepting anything they want. If we can save 50% on certain drugs, that means we can buy many more drugs in that place and still get the same quality of care that we had before. So we're really trying to be more business oriented with pharmacy, because that's what pharmacy is supposed to do. They save money in order to obtain more medications and treat more people. So that's our goal, and we want to make access real easy so they can potentially in the future pick up medications, all their medications. This is a fantasy right there in the clinics. And with street psychiatry, my goal is to have the ability to provide the medications right out there in the community. And I don't mean just long-acting injectables. I mean perhaps even bottles of pills. You know, so they don't have to worry about anything. We come and provide it. Transportation is no longer an issue for them. That's usually one of the biggest issues they have. So I think this is going to be a real game changer. There's a lot of work to be done. There's a lot of bias that exists in DMH over how pharmacy should be run. But I think I'm trying to really move it into the 21st century. So that's pharmacy. I've also been put in charge of CRM. You know what CRM is? Most people do. Yeah.
Good luck.
Community resource management, right? Mary Marks, and she retired, by the way, we're gonna miss her. So that's been put under me, and so has the TAR unit, which is the treatment authorization. They've been functioning as separate units. My goal is to combine them and use the resources of both to really develop a really good system that's transparent, that's functional, that's super efficient. And I think we can do that. We're already meeting weekly, TAR and CRM together, leadership together, to develop really a system. Start over and say, what is it that our patients really need? And how can we use our unit resources in order to provide that? So it's going to take time, but I think we can do it. And everybody's really interested in it. And so I think we're going to provide a system that's much more efficient shortly. I've also been made the point of contact for DMH for everything that has to do hospital, everything that has to do with community. I know Pat and I have talked considerably about many things. I've talked to many other people and mothers with sons in jails, prisons, who are not getting substance use disorder treatment, something that's key. And we're trying to work through each problem individually. And so we work with the hospitals to ensure that they're getting all of the information they need from both the records and from moms and dads and family members who really want to have wonderful histories that they've developed themselves about patients over years. Those need to get to the hospital staff that's taking care of the patients, so that's our goal there too. I forgot all about, backtrack a couple steps, very invested, as Pat said, in co-occurring disorders or dual diagnosis, whatever you want to call it. We need to think about this in a whole person perspective. We cannot fractionate, put substance use treatment over here and psychiatric treatment and mental health treatment over there. That's just not how human beings work. That's not how our brains work. We can't compartmentalize things like that. We're not pieces of pie as human beings that we can separate and they're never going to attach again. So I'm really invested in bringing substance use disorder treatment to DMH. It's been a real hurdle for us because government's not too happy about that, right? They say, that's not your role. That's the role of Department of Public Health. And so by the way, Department of Public Health doesn't believe that too. They want to provide psychiatric treatment there as well. So we're trying to really bring that in. We've got the RAND organization, the think tank, who's developed a toolkit for us to bring this in. I'm working with ISAP, the Integrated Substance Abuse Prevention, or program, I'm sorry. And they work at UCLA. We're trying to double their budget so they can really provide a greater force for us. And we've gotten the okay from County Council to really bring this in and really start providing treatment today and not wait for the legislation to change, which could take months at least, probably years. So we're going to start that treatment. I'm very passionate about it, and I believe that every single person of the mental health team needs to be responsible for substance use disorder treatment for patients. And they all have to be done at the same time. The psychiatrist will stop saying, that's not my specialty, and they'll start saying, how can we help you? This is part of your mental disorder. How can we help you get over this? This is a risk factor for you as a stressor. Yes, sir.
How is that going to be used in lockdown facilities?
Like in inpatient facilities? Good question. And this is also a hurdle. There's a lot of biases. In the old days, we psychiatrists and mental health professionals, especially in California, were taught you can't deal with a mental health disorder until you solve the whole substance use disorder, right? And I actually believed that when I was training long, long ago, because that's what I was taught, and it seemed to make sense. But I've changed 180 degrees. I'm so passionate about this that you cannot separate the two. It just doesn't work.
Even in jail, a lot of it don't know.
Even in jail, right. And I agree with you. And how are you going to change that? That's going to be difficult. It's going to take a long time. We don't have enough control yet, DMH. The goal is, as I said, for us to take over all mental health in the county because we think we can provide it better. And that means perhaps even the jails take over mental health, which we used to have, but no longer have. And with the hospital systems that we contract with, they're all our contractors. We need to improve our contracts so there are incentives for good treatment, so that they potentially get paid what they deserve, and that we oversee it really carefully so we make sure that our patients are getting the best care possible, which is the whole person approach. That means you give the substance use disorder treatment up right there along with the mental health treatment. I don't even say there are two different treatments, it's the same treatment, so I don't even want to go there. It's the same exact treatment. So that's our goal. That's going to take a long time because we don't have direct control over these contractors yet, but we need that. So, and in the meantime, we're going to try to establish better incentives so that they're going to be willing and interested for their own benefit, selfish benefit, to take care of our patients in the best way possible. So that's the goal. That's going to take a while. But yeah, you brought up a good point about the jails. You guys all know about the initiative of Los Angeles County now, right? They're not building a prison, they're building a mental health hospital, right?
Yay!
And this is very much because of, Dr. Sharon's personal push. He's very passionate about this. He does not want mentally ill incarcerated because of the, situation related to their mental illness. So our goal is to really engage in a massive diversion program that's going to take many more resources than we have now, but hopefully there'll be funding for it. And the goal is to divert them, meaning that we'll get them out of jails and prisons as soon as possible. But also, not just that, that's a small part of it. The goal is just to have them miss jail and prison altogether, that we divert them before they get in trouble, right? And that means that we have to be responsible, take it to our personal responsibility to ensure they're getting the mental health resources that they need so they don't take a wrong turn in life, right? Because once they do, it's that much harder to bring them back. So it's a big initiative. It's going to take a lot of effort, but Dr. Sharon is very passionate about that, and so are all of the committees, and I be one of them. Yes, ma'am?
The new innovative program, the TMS, the treatment.
Yeah. You want to hear about that?
Yeah.
Okay, so TMS, our program is, we have, it's an innovation program. I'm sure you're already aware of this. TMS, for those who don't know, magnetic stimulation, it's like a kinder, gentler ECT. It's like akin to an MRI for the brain, and it changes how the cells fire and all of that. It's non-invasive, it's really simple, it's extremely safe, and it functions as a pretty good antidepressant. So we are putting one of those machines inside a van and having the van go to all of the clinics, as opposed to all of our patients to go to some